As you know, we're going to be talking about a syndrome which is highly prevalent, yet poorly recognized, and even when it is recognized, is poorly treated. And it's the hope of all of us that at the end of this meeting, that we will be just that little bit better in the recognition and the treatment of the disorder. Before beginning, I want to give a special word of thanks, of course, to Dysautonomia International and Lawrence Stiles for spearheading this meeting and for really putting it together, publicizing it, making everybody aware of it, and persuading me to put it on. And it was, I think, a substantial amount of arm twisting that needed to go on to get me and my team to participate in this. I think already I feel the arm fractures that I received as a process were worth it. I also want to thank members of my team who stepped in to help with the little details that always get left to the last moment. And I'm not going to mention many of you by name, but Sharika Rajan in particular, who played a major role in filling in the kinds of things that I'd forgotten to do, and this would not have happened without her. I do also want to mention Christina Torrant and to thank Teva Tarrant for really providing the impetus for this to happen, and I really do appreciate your presence here. I understand just how difficult this must be for you, and I think perhaps if there's one message that I can convey is that going forward with meetings like this, and hopefully even as a result of this meeting, that we can say never again for events like this. And I think that should be all of our missions with respect to this syndrome. So we are a little late, and I want to get things moving along. So the first talk of the afternoon will be by Christopher Gibbons, who's an associate professor of neurology at Harvard, and he's going to give an overview of the postural tachycardia syndrome.
Excellent. So good afternoon. So as you heard, my name is Chris Gibbons. I'm a neurologist here. And just as a bit of background, so I've had an interest in autonomic disorders for quite some time. I'm actually the current president of the American Autonomic Society, and so I have a lot of interest in disorders, in particular postural tachycardia syndrome, other dysautonomias. But the focus of today will be really about postural tachycardia syndrome. And I thought we'd start off with some background, an overview of how we got to this point, what is the history of this, and a little bit of perspective. Now, whenever starting off a discussion, I'd like to lead in with some disclosures. Now, I am a neurologist. I just mentioned that, and this is an important point because my perspective on this disorder may come from a neurology-focused lens. And as we've probably been aware, there are a lot of physicians that may treat a disorder that crosses multiple boundaries. So whenever we're thinking about a problem, we need to really consider where we're approaching this from in order to get an answer. And so as a challenge, I would say I'm trying to be very broad in my delivery of data to you, but it's important to recognize that, again, there are different perspectives on this, and this is really going to come through as a neurologist. So postural tachycardia syndrome, I want to provide some history to this. What has led us to this date? What is the clinical definition of this? What is the physiology? How does this happen? How many people deal with this? What is the epidemiology of this disorder? And then finally, what is the pathophysiology? What causes this problem? What goes wrong? How does this develop? And we're going to kind of carry this theme through into other talks as the afternoon goes on, so you're going to hear a lot of different bits of information throughout this afternoon. Now, I was curious, based on the symposium, where we were today. So I Googled POTS, and I did this week just to find out where things stand. And it turns out if you Google just POTS, the entire first page of Google will pop up with postural orthostatic tachycardia syndrome, or some variant of that term. and not a single thing will pop up related to your cooking ware that everybody uses. So pots are in everybody's household. You'd think this would be something that would be incredibly common on Google, but amazingly, this has risen to the social consciousness quite a bit up. And I think this is certainly in large part to work by Dysautonomia International and trying to make this a problem where people are aware of it. But it's pretty remarkable if you think about it. So the first entry on Wikipedia, which was the first entry on Google, was in 2004. So prior to that, Wikipedia had nothing on this. Of course, Wikipedia is not that old either, so this really comes back to, well, how old is this problem? If you go back to the medical literature, the first description of postural tachycardia syndrome was in 1982. So we're really not talking that long ago. 1982, Rosen and Cryer described this disorder. But it seems an amazing coincidence that just now in the last 30 years, something has popped up that we'd never seen before. So this is an important thing to look at historically. And this initial description by Rosen and Cryer was quite, I think, informative because we have a very clear description from their report about what many of us may see commonly. And so, apologize for everyone, that's some emergency going on in the hospital. We'll have to ignore that in the background. So we can close the doors if that helps. So the description, a patient with a disabling postural tachycardia without postural hypotension, in other words, without a drop in blood pressure, had symptoms that included palpitations, weakness, abdominal and leg pain, lightheadedness, headache, diaphoresis or sweating that occurred only in the upright position. She was shown to have an enhanced sympathetic neural response to standing, and in this case, it was characterized by an exaggerated release of norepinephrine in the standing position. However, her cardiovascular responsiveness was intact. She was unable to maintain normal sodium balance, and this was measured by a sodium excretion that seemed to be smaller than should be for someone with normal volume. So it was believed that sodium loading, or in this case, sodium loading with fluid and administration of fludrocortisone would largely correct the hemodynamic abnormalities. In this case, it did and really made a substantial improvement in symptoms. This was the first characterization of this problem as postural tachycardia syndrome. But of course, it seems a little odd that we wouldn't have heard anything about this before 1982. So is it really just a disease of the modern era? Have we somehow managed to create a new disorder that didn't exist prior to this? And the answer is no. This is something that has been around for a long time, and it holds many different names. And if you go back to 1871, Dr. DaCosta described the development of irritable heart syndrome. This is well and clearly defined as symptoms of orthostatic intolerance, generally dizziness, chest pains, palpitations, fatigue that occurred in the upright position, associated with a very high pulse while standing, typically 120 beats per minute. And he describes in all the immediate effect of the postural change or the change in position was most striking. I think that rings a clear bell in terms of what we're talking about. Now, the orthostatic tachycardia at that time, really affecting soldiers, it was a time of war, this was really where the focus was. It occurred while marching, while fighting, after a bout of diarrhea. Clearly, hygiene was not available in many cases in this way. So fluid loss was presumed to be underlying disorder to this condition going back. But then things kind of went quiet for a while. We didn't hear much about it until, unfortunately, we had another war. In World War I, Sir Thomas Lewis described this as soldier's heart and effort syndrome. Similarly, this is postural fatigue aggravated by exertion and associated with chest pain, excessive sweating, fainting spells, and he described giddiness or just feeling of lightheaded or dizziness in the majority of patients. Now, the average resting heart rate was 85, but when standing up, this heart rate went up to 120 or 130. And again, this is sounding very similar when we talk about a postural tachycardia. And there was some degree of possible blood loss in some of these individuals, so it was a little bit more of a mixed group that he was describing at that point in time. But leaping forward now, again, we've jumped forward in history to 1982 from 1919. So it seems, again, there's this big gap. And what's happened during this period of time? The descriptions were very similar to all of these disorders, but it's unclear why previously only at a time of war were these cases described. But it turns out if you actually go through the literature and you're a little obsessive about this, you can find a lot of reports over many, many decades describing the same thing in different ways, and a lot of different terms have been used. So as you can see from here, from the original Da Costa syndrome, followed by a variety of terms that have been used to characterize this particular disorder, have come out over the years. And they, again, describe a similar thing, but in a low enough frequency that the names did not stick. We did not carry through to any degree and familiarity with this across physicians as a group or across the population. So this is a problem where, again, small numbers and changing names, this has made it a very difficult disorder to characterize. So let's step forward to present day. What is our clinical definition of a postural tachycardia syndrome? Now, this is an increase in the heart rate of 30 beats per minute without orthostatic hypotension, and that's an important distinction because orthostatic hypotension and POTS do not coexist. This is a separate disorder. Now, a standing heart rate of 120 beats per minute is also considered a criteria. So even if it goes up by less than 30 beats per minute, but it hits 120 while standing, that also meets criteria. But there is this important distinction in the younger population. So individuals who are kind of in the teenage years, we typically use a standard of 40 beats per minute change. And this is primarily because of the typical increase in heart rate that is normal in that population and definitely exceeds 30 beats per minute in a large percentage of people. So up to 20 to 25% of people of that age may have a heart rate of that increase of that rate. Now, this is also accompanied by symptoms of orthostatic intolerance. So you must not just have a tachycardia, you have to have symptoms associated with this. So we're trying to define these as separate entities, a postural tachycardia or postural tachycardia syndrome. So how does this happen? So certainly, if we were on the moon or in space, we wouldn't have POTS as an entity. Gravity is the problem here. We have an issue where gravity is causing a shift in blood from the central vascular compartment to the peripheral vascular compartment. And this occurs very rapidly while standing up. And you may have a shift of a half to a full liter of blood in a very short period of time from the central to the periphery. And as a consequence, we have to go through an enormous number of hemodynamic changes to counterbalance this large shift in fluid. So generally, when we're looking at this, there's a gradual increase in heart rate that's completely normal, very rapidly, that's part of a mechanical exercise reflex, followed by an increase in heart rate up to 30 seconds, and at which point things taper off and a new baseline is met. So there's a very rapid change that occurs in the first 30 seconds of standing. And this is really what we see in a normal person. They may have a low resting heart rate, an immediate increase with standing, a gradual increase in the heart rate, followed by the establishment of a new baseline within 30 seconds. So this is a pretty dynamic process and what we'll see in the average person. And in certain scenarios, we may decide to put somebody on a tilt table test. If we're worried about fainting, having an accident while standing, we want to measure this in a controlled environment. So on a tilt table test, this would be a normal response. You see the baseline heart rate, a slight increase over time that's maintained, but very little change overall. This is very different than this picture. This is somebody with a postural tachycardia. You can see the baseline heart rate, which is significantly more elevated than somebody whose heart rate is at 60, with a substantial increase very rapidly. And this baseline is maintained throughout the entire duration of the study. So again, a significant tachycardia in response to gravitational stress. So this is the visual description, but this, I think, is what we're all talking about from a physiology. Now, the symptoms that go along with this, some are easy to explain. Being lightheaded, dizzy, perhaps getting tunnel vision. In this type of scenario is not surprising. Palpitations. If your heart rate is 140, you're very likely to feel palpitations in your chest. You may be fatigued. You're trying to exercise and your heart rate is 140 when you stand up. Of course, you're going to be exhausted trying to exercise further. So this is a very common set of complaints, and we expect that. A number of these other complaints may be associated. You can certainly see shortness of breath and hyperventilation if you're having palpitations. It's not surprising. Chest pain, of course. Nausea may occur. There may be changes in color of the limbs. The lower extremities may be kind of reddish potentially bluish. They may be cold. And headaches are not uncommon. And of course, either pre-syncope, feeling like they're going to have an episode of passing out, or true syncopal spells are also common. Now, typically, we find that there's a sudden onset. It's a relatively abrupt cause in a large number of people. It may be an illness that's relatively minor, a common cold. It could be a traumatic event, a car accident. It could be a surgical intervention, something planned, a surgery, and afterwards this develops. So the average person with this will typically be a young person, generally athletic, who's often thin. It's definitely female predominant, about 4-to-1 ratio. And it's very common to be associated with syncopal spells. And in some cases, we hear people who develop this much more gradually over a longer period of time. That's a more unusual description, but we do see it. And it may reflect a different pathology underlying this disorder. And we'll talk more about this. So what causes a postural tachycardia? Well, actually, any number of things can do this. Certainly medications, hospitalization, if you run a marathon, if you're in space, heat, diarrhea, other procedures, any number of things can cause a postural tachycardia. But that's not what we're talking about. What causes postural tachycardia syndrome? So we're not talking about just the increase in heart rate. We're talking about the whole constellation of symptoms that go along with this. And the short answer is, well, it's complicated. The long answer is, it's still complicated. We don't really know a lot, but we have a large number of theories. We do have some evidence, and I'm hoping to provide you with what information we do have, and I think this will carry through the next series of talks as well. So who is at risk? So we certainly know that the disorder really affects women predominantly, but certainly a fair number of men have it as well. It's in younger people. There is a very rough estimate of 500,000 people affected. This is really based on very limited data, so we don't really have a good idea of how many people may be dealing with this problem. And this is clearly an area we need additional work. There is also a question of how many people may be misdiagnosed or diagnosed with other disorders and overlap disorders, whether chronic fatigue or anxiety. So the question is, again, in the population, what are we dealing with? And that is a tough one to pin down. We're not really sure. What causes this problem? A number of theories. Try and go through these a little bit and describe how we may get here, but it's based on a number of different evaluations, including just a low volume hypovolemic status, some question about whether exaggerated lower body venous pooling occurs, physical deconditioning, but in a specific way, some degree of central autonomic regulation failure, or partial autonomic denervation, as well as many other things. We'll try and go through some of these in detail. Now, I want to transition to what we're referring to as a POTS phenotype. What is the characteristic of somebody with POTS? And there are different descriptions that we see now in the literature, and I'm trying to outline this so that it makes a little bit more sense, because if you're reading about this, you may hear conflicting results, and part of this is because the different phenotypes do respond differently. So neuropathic POTS, hyperadrenergic, hypovolemic, there are certainly genetic components, autoimmune, deconditioning, and then medical diseases. I'll try and highlight, first of all, these up here, which I'm really considering the primary POTS categories, where people may have a specific disorder that we consider postural tachycardia syndrome. These in this lower category, I'm going to discuss as a separate group. Neuropathic POTS. Now, this is really based on the concept that denervation in the lower extremities, resulting in impaired norepinephrine release, could result in an inability to respond to orthostatic stress appropriately, or an orthostatic tachycardia. Now, in our own work, we found that approximately 38% of the group referred to us had neuropathic POTS as the underlying etiology. And this was defined by an abnormal nerve fiber density in the distal leg. So biopsies, we kind of looked on the pathology, found that they're denervation. So this is a skin biopsy and epidermal layer here. And you can see in the red fiber shown here. But what we see is a denervation in individuals with neuropathic POTS. Now, it's important to recognize, again, I wanted to highlight that this is through the lens of a neurologist. So these are people referred to me because I'm a neurologist with an interest in neuropathy. So Is this referral bias elevating the number of people with neuropathic POTS? Absolutely, that's a possibility. We don't really know because, again, we don't have good population-based studies. But this is what we're talking about. Now, physiologically, what does that mean? Well, if you have blood vessels in the skin and they have lost their nerves that are surrounding them, this can clearly cause a problem when you're trying to have reactive vasculature when you stand up. So can you vasoconstrict appropriately? Can you adjust your peripheral vascular resistance and manage blood pressure? If not, you will certainly develop a tachycardia and as a response, develop symptoms. So this is what we're thinking about when we consider the term neuropathic POTS. Now, there's some interesting differences between people with neuropathic POTS. So they tend to have a lower resting heart rate. They tend to have reduced heart rate variability, so the fluctuation in heart rate in response to deep breathing. It's typical that in neuropathic POTS, this may be lower. It may, in fact, be still normal, but it would be lower than somebody who had a different form of POTS. They may have lower maximal heart rates. And this is a Valsalva maneuver here. This is somebody exhaling against pressure or resistance, and you can see the fluctuation in blood pressure in response. There's a pretty dynamic change over about 15 seconds that occurs, and a fairly dynamic change in heart rate. Now, in people with non-neuropathic POTS, we see a very significant fluctuation in heart rate here, very dynamic. In neuropathic POTS, it's more of a normal range. It's not abnormal, but it's not the same as somebody who has non-neuropathic POTS. And in this stage over here, this what we call phase 4 blood pressure overshoot, there's typically a significant increase in blood pressure here, seen in the non-neuropathic group. But in those with neuropathic POTS, it's relatively normal or even blunted. So again, there's different pathophysiology between these phenotypes, and it's not all the same. Now, I want to try and contrast this with something referred to as hyperadrenergic POTS. And again, based on where the referral is coming from, 30 to 60% of patients with POTS may have some evidence of an increased central sympathetic drive. And generally, as a chemical, what we look for is norepinephrine release in the standing position. And if this is more than the normal value, which is about 430 picograms per milliliter, then this is suggestive of an increased sympathetic drive. And in many cases, people have greater than 600 or even up to 2,000. So this is suggestive of a hyperadrenergic state, and thus the term. Now, there's typically an increase in blood pressure as well on either standing or tilt table testing. Now, we just talked about the characteristic Valsalva maneuvers, these hyperdynamic responses. And it's really important to be aware that there are a number of things that can contribute to this state that you need to be thinking about. So whether medication effects are contributing in some way to the disorder, either causatively or exacerbating the problem. But anything that blocks norepinephrine transport could have an impact on this. So certainly many of the tricyclic antidepressants need to be considered, any of the other NET inhibitors or stimulants, which are common these days, particularly use in sleep disorders, ADHD. So these are all medications that need to be considered when you're thinking about somebody who has a hyperadrenergic state. What about primary hypovolemia? Again, depending on where the patients are referred to, this kind of focal bias occurs, but again, approximately a third of people had evidence of hypovolemia as part of this, and this was evidence of low sodium excretion over 24 hours, and this suggests that you're holding on to salt and water to maintain fluid balance. Now, the problem, and many of these people get substantially better with fluid expansion, so there's this question of hypovolemia as a cause. It's also associated reduced red cell mass, plasma volume, and again, it's important to recognize that there are many ways you can get to a hypovolemic state. GI disorders in particular can cause focal problems. There's been continued interest in the renin-angiotensin-aldosterone systems as a possible mediator of disease in this particular state as well. There's also been this interest in partial denervation of the kidneys, renal denervation contributing. This would reduce red cell mass, potentially cause an anemia. And again, in this situation, something like erythropoietin might have a significant impact, but this would be a targeted therapy for a specific disorder. What about evidence for genetic variations? There's been a lot of interesting work, and a lot of this is challenging, though, because there are so many variants in the population and so many different disorders described of one person that it's difficult to figure out what this means to a group as a whole. So one of the first genes encoding a norepinephrine transporter was seen to cause POTS in one individual. However, in contrast, an identical twin with a slight variant in the mutation didn't have it at all. A fair number of studies have looked at nitric oxide synthase and some variability in the promoter regions. And these have also caused differences in what we think of as vasoreactive responsiveness or blood pressure responsiveness, withstanding and norepinephrine release. There's been a lot of work on beta-2 adrenoreceptor polymorphisms, so changes in the capacity of the system to respond to physiologic stress. Been some interesting work on dopamine beta hydroxylase and how it may impact sympathetic activation. And then finally, there's been a lot of work in Ehlers-Danlos, particularly the type 3 benign hypermobility form. This seems to be really an interesting, compressive process where vascular distensibility may be directly impacted. So again, a lot of different area here, even under this one small phenotype. So again, this is a challenging problem. We're covering a lot of territory in a very short time. What about autoimmune? This is an entirely separate issue. What type of autoimmune process potentially could result in POTS? Now, there's been some very exciting work looking at the acetylcholine receptor to the autonomic ganglia and how antibodies targeted there may in fact cause autonomic failure. And the first descriptions of this were in individuals with pure autonomic failure. And high antibody titers resulted in severe orthostatic hypotension and profound autonomic failure. The system just didn't work. Severe constipation, the bladder didn't work, bowels didn't work. It was completely devastating. But that's at very high titers. There have been a number of patients with very low titers that have been thought to perhaps be as a possible explanation for a postural tachycardia. There was a report that 1 in 7 patients might in fact have antibodies to the autonomic ganglia. Should be noted that that report was specifically referring to those more indolent cases, those slower progressing cases, not somebody who developed something acutely after an illness. And those are a very small number of subjects. So it's unclear what we're talking about in terms of a population, because the actual number of cases that have been positive total in the United States have only been about 300 positive antibodies, of which more than half have no symptoms of autonomic dysfunction at very low titers. And a few select ones have severe autonomic failure. So again, what this means in terms of an evaluation and treatment, we don't yet know. But there's also been a lot of interest in other autoantibodies. Beta-adrenoreceptor antibodies, muscarinic, N-type acetylcholine receptor, voltage-gated potassium channels, and then the question of post-vaccine development. So there's been a lot of discussion, a lot of interest in, and again with vaccines, any number of disorders. In many cases, these are small numbers. They're associated, and it's unclear with a disorder that may have a prevalence of, at this point, 500,000 people in the United States. There may be some association with antibodies. So we don't know yet, particularly these, what this means. There's been no evidence that causation is a fact here, but association, yes. And certainly this is an area where we need a lot more work to really determine what to do with this information. Deconditioning. Deconditioning is a loaded term. So what does that mean to most people when I say deconditioning? That means not doing anything, complete inactivity. This is somehow implying there's a degree of fault in this process. But it's important to recognize that's not what this term is really meant to describe. Deconditioning here is a physiologic term, and it's really based on evidence from NASA and a lot of spaceflight work that has highlighted microgravity or loss of gravity will result in a cardiovascular deconditioning and an inability to fight against gravity. So all the first astronauts, when they returned to Earth, developed a postural tachycardia and had symptoms, all of them. And based on this recurrent process, they finally figured out that you need to exercise astronauts in space in order to prevent this from happening. So that's why if you now see the astronauts are actually strapped with elastic bands to a treadmill in order to develop the physiology and protect themselves against this postural tachycardia on return to Earth. So the question is, though, does that in some way mean that POTS is secondary to inactivity, that it develops as a cause or due to some form of inactivity? And the problem with that is that most people with postural tachycardia syndrome report being very active. They're athletes. They're often in either in college at Division I athletes or in high school on the varsity team. So something doesn't quite fit with that scenario. So these are people who are generally very active, and after some mild illness, develop a significant number of symptoms. So it doesn't seem that the deconditioning itself results in POTS. There's sort of a disconnect here. However, there's been a lot of work suggesting that maybe deconditioning is a kind of common final pathway in this process. So if you've been sick for a long enough period of time, deconditioning can absolutely set in and may play a role in your ability to recover. And so work out of Dallas has suggested that individuals with POTS maybe in general have a smaller heart size. And as a possibility, this may predispose them to developing a postural tachycardia. And in fact, their studies suggested that individuals with POTS had a cardiac mass that was in fact 2 standard deviations below an age and gender matched comparison. So this was a significant difference in population. And this was the study looking at that. Now, I also want to transition to medical disorders. Now, there are a large number of medical disorders that can certainly be associated with a postural tachycardia. And I want to distinguish between something that I'm characterizing as POTS versus a medical disorder with a postural tachycardia. And I think this is an important distinction. So I am not going to classify somebody with, say, diabetes and POTS as a POTS syndrome. I'm going to call this a diabetic autonomic neuropathy because the problem is the diabetes. We have to target that. There may be symptomatic and treatment involved for the symptoms that are associated, but it's important to understand where the disease starts so that we can treat it appropriately. So for example, if somebody has ulcerative colitis, a GI illness, and results in volume depletion and a postural tachycardia, we need to treat the ulcerative colitis if it's not aggressively being treated. Treat the hypovolemia. And if those cases are treated effectively, then in many cases the symptoms disappear. So it's important to recognize, again, this isn't primary POTS, this is a secondary postural tachycardia. The same thing, if you have a severe anemia, you will absolutely have a postural tachycardia and you'll be very symptomatic. But if we ignore the anemia, we're not going to make anything better. So again, this is an important distinction. And so I want to, again, just highlight that point that an underlying disorder that's causing a postural tachycardia should be treated. And we shouldn't think of this as POTS and treat that first because, again, it's a secondary effect and we need to have to go after the initial process. Now, I guess a major question. If it's just a postural tachycardia, why is it so difficult to treat? So for anybody who's strolled through the paper version of the PDR, the physician's desk reference lately, it's getting increasingly thick. We have thousands of medications out there. Cardiologists are outstanding at modifying heart rates. How can we not just fix this? I mean, at this point, it seems such a simple question. Why can't we just fix a postural tachycardia? Well, it's because it's not just a postural tachycardia, and I think that's quite clear. So many people have a severe disability associated with this, and up to 25% may be unable to work or go to school as a consequence. So it's an important thing to consider that it's not just a tachycardia. And it's also interesting that the challenge we face is that the symptoms may not be linked in any way to the tachycardia. Many people are clearly worse when they're upright, but they often have many symptoms when they're supine as well. And so the challenge, of course, is that if we make a tachycardia go away, we may not, in fact, get rid of the vast majority of the symptoms. The orthostatic intolerance often correlates more with severity of depression and perceived chronic pain. And it's an interesting description that chronic pain is often now being used as a description of many people with a postural tachycardia, but we don't really understand that. It's relatively new, and the question of why are people in pain is unknown. We really have limited longitudinal data, so it'd be wonderful to understand what happens to people with POTS. Again, we've had data going back many decades, but we don't really have good epidemiology and longitudinal information. We don't seem to have an increase in mortality in most cases, and obviously that's a concern with associated comorbidities, but we also don't see that many older people with the problem. So where does it go? What happens? And these are unknown questions. The only recent study of surveys of actually pediatric individuals with POTS was a 5-year follow-up. And in that case, it was an aggressive treatment paradigm, but the good news there was that 86% reported symptoms had either resolved, improved, or were very intermittent at that point. So that was actually good news. And this is a very recent study. And 71% reported kind of good to excellent health. Now, the challenge, of course, is that was a very, very focused treatment group that received very high-level care to begin with, so it's unclear if that in any way passes on to the general population. We clearly need a lot more information, particularly in the non-pediatric population. What happens to the general person with POTS? That we really have no long-term follow-up data on. So at this point, I just want to kind of do a take-home summary of where we are now before we kind of move on to additional discussion. So it's clearly poorly understood. There are a lot of different mechanisms, and there are a lot of underlying disorders that could contribute or dictate outcomes. So it's important to recognize that tachycardia is potentially caused by a number of different reasons. We have to look for the underlying disorders, whether there's a thyroid abnormality, an intrinsic cardiac process, an inappropriate sinus tachycardia, whether some pheochromocytoma, a norepinephrine-releasing tumor, could be contributing, whether adrenal dysfunction may be at part of this. And we need to understand more about why this happens to kind of the younger population. Why is there a gender difference? And the symptoms, why are they postural in some cases but not in others? We have a lot of pathophysiologic mechanisms we've discussed, anywhere from autoimmune, genetic, hypovolemic, deconditioning, intrinsic cardiac. So there are a lot of different ways we can approach this. And I think this has been part of the challenge from the medical community is, again, when we're looking at this through the lens of a neurologist, we may see this differently than if I'm a cardiologist. And it makes it complicated to discuss this, particularly if these groups don't necessarily intermix on a regular basis. And certainly comorbid disease. We need to make sure that not just postural tachycardia, but any other illness is treated as well. It clearly dictates outcomes. Now, we clearly have a lot of areas of unanswered questions and lots of areas of need. Now, we certainly need long-term outcome data. We're missing, that's a huge failure. We need to have better understanding of the mechanisms. And once we develop those understandings of the mechanisms, and we're getting further along in this, how do we put this into a clinical evaluation? So at this point in time, I've discussed very quickly dozens upon dozens of possible mechanisms. How can we distill this down to a fairly simple clinical evaluation? Because a primary care provider who looks at this list is not going to see an easy out. There isn't going to be a way to solve this problem quickly. We clearly need more physicians who are familiar with this disorder. If it's as common as we think, then more training clearly is better. And finally, we also need comparative treatments. We need to understand what therapy is better than another therapy and why. And is there a specific group that may be best served with this? So these are all questions we need answers to. And so it's, again, an area we're really stressing, trying to push forward on, but it's an ongoing challenge. So at this point, I'd just like to stop and thank you for your attention. And we'll be moving on to our next speaker, Roy Freeman.